Okay, hello and welcome. My name is Katie Williamson, and today I am with Dr. Shannon Thorsteinson. She is in Atlanta, Georgia. She is a dentist and a member of O'Shea Dentistry. And Dr. Shannon is an expert not only on the teeth, but also on the airway. And we're going to talk in this interview about how dentists are really the ones these days that can be the most important people in a patient's life to not only identify, but also to address sleep issues, and specifically sleep issues that have to do with poor breathing habits. So there's a lot to talk about today, and I'm really grateful, Dr. Shannon, for your time and your expertise. And I went to your office as your patient, so it's very special that I have this opportunity. And briefly, I want to mention how I got to your office. I read the book Breath by James Nestor, which is an amazing book, and I was really obsessed with it. And it's also published in Spanish, which is an amazing thing too, because not all resources in English are available in Spanish, but it is available in Spanish. And I read about a doctor in this book called Dr. Belfour, who works with a specific device that we're going to talk about. And I actually called his office, or I emailed his office, and they put me in touch with you because you have worked with Dr. Belfour before. So that's how I got connected. So thank you to James Nestor, because, like his work in the world has also helped so many other people. It's helped me, and it's also connected me to you. So without further ado, I would like to give you the space that you can introduce yourself and tell us about your path, not just as a dentist, but as a person, like how you came to be a dentist and how you came to focus on the things that you do in your practice, because you're certainly not a normal dentist.
Oh, thank you, Katie, for the introduction. It was a pleasure to meet you, and it was my honor to see you as a patient. So I am really thrilled to have a chance to talk about all this, because I almost have to stop myself from talking about all this stuff all the time, because not everyone's like you and wants to hear all of this. But I really spend all my time learning about it, and it's an ever-evolving field, so it's really exciting for me. But yeah, I'm a general dentist, and it's a really exciting time to be a general dentist because of all of the research that's coming out that really puts us at the intersection of a lot of different fields. So, it's hard to say kind of how it all started, but I've been on a journey maybe the last 4 years or so, really kind of subspecializing and learning everything I can about airway health, because I have so much opportunity as a dentist to make a positive impact on airways, and it's my passion and now my specialty.
So when you got into dentistry, did you know that dentists are also like identifying and addressing sleep issues? Did you?
I did know that. So sleep dentistry has been a really mainstream field for a long time. And in my training, I knew about that. I did some education on sleep appliances. And that's an important distinction, I think. In the general population, we think of sleep dentistry as, we call them mandibular advancement devices, like sleep appliances that you wear on the top and the bottom arch that move the lower jaw forward. And it's a really great field, and that has been happening for a long time. I do make the distinction between sleep dentistry and airway dentistry, and that, and they're linked for sure. That sleep dentistry does serve a really important purpose as far as getting people breathing right away and offering something that is needed. My focus is more addressing the underlying causes of why we got to the point of having a sleep issue, so that we can address it on a more permanent basis on a foundational level.
Okay. So years ago, I got a book in my hands, and the book was called Nutrition and Physical Degeneration by Dr. Weston A. Price. And that book is actually the reason why I started this blog, because it's not translated in Spanish. And that was my main thing with the blog at first. I was only sharing about this book. And in that book, we learn that humans are designed to be wide. So that means they're designed to have wider faces where all of the teeth can fit. And they're designed to have wider pelvises, which is helpful in childbirth. Or I say we are designed to be wider so that our teeth fit and we don't need braces. And also so that our airways are wide enough so that we can breathe through our nose and not through our mouth. So I think that Dr. Price's book was so special and such a gift to humanity, because we can see very clearly not only what human design is in terms of width of mouth, width of body, and width of airway, but also we can see what happens, and that's why the book is called Degeneration. We can see what happens when we stray away from our human design. And there's many things that influence the way the face is shaped. Modern faces are so narrow, like mine. I had braces twice. I've had lots of teeth taken out. And so I think that maybe we can segue into, why is the modern face so narrow? I think a lot of people think the way that I look when I see myself in the mirror, oh, that's just my genetic destiny. Like, my face is the way it is because that's what my genes, but that's very far from the case. And a piece of the puzzle we know from Dr. Price, but there's a lot more to the picture and understanding how the face develops.
I know that's a fascinating topic for me, because I agree. And it's obviously the subject of lots of ongoing research and controversy in some ways. But when I'm evaluating a face, I try to look at, of course, 3 dimensions. So where are we in width, where are we in height, and where are we from front to back? And there are certain components of our makeup that are genetically determined. And there are certain components that are determined more by our function and our environment. And that field of epigenetics is also a new and growing field that we're learning more and more about every day. And really is, I think, the key to learning a lot about how this happens. But Weston Price's work is obviously foundational for all of this. And what we know is that, and what I see, is there are different portions of the face that we have influence over. This part, this upper third, we divide the face into thirds when we're designing for aesthetics. So this top third is really more of a fixed structure. So this is determined more by our genetics. But anything below that, the lower 2/3 of the face, we have influence over how that grows. And that is determined by how we breathe, sleep, eat, swallow. And that really goes back to how the tongue is functioning. And we know by studying anthropology that our faces are smaller than they used to be as a population. So 4 generations ago, we had the Industrial Revolution, and we know that we started eating differently as humans, right? We were able to preserve foods, we're able to eat softer foods rather than a harder, crunchier diet. What's so interesting is when we study the skulls throughout those time periods, we can see that the jaws are shrinking smaller and smaller. And so what I tell families too is there's a lot that we can do to influence, but we're also all starting off kind of behind the 8 ball, right? So when we're born, even if we make every right choice as far as how we're fed and how we breathe, we still are at a deficiency if we compare ourselves to previous generations. And a lot of that's, I joke, it's based on what your great-great-grandmother ate, So it's such an interesting topic, but there's a lot that we can influence, but there is a starting point for everybody. And it's important to kind of just be aware of.
Yeah, that totally makes sense, because we're talking about, his book is called Nutrition and Physical Degeneration, and we're talking about our ability to regenerate, but it can take more than one generation, and that makes sense to regenerate. So one of the things that we learned from Dr. Weston A. Price is the importance of a preconception diet. So a diet really nutrient dense for mom and dad, even before they conceive, and then mom during her pregnancy, and also mom when she's breastfeeding. We learn about the importance of natural birth when it's possible. We learn about the importance of breastfeeding. So that's so fascinating too, because most people talk about breastfeeding and they're talking about, oh, it's good nutrition from the mom. It helps you form your microbiome. It's spiritually important for the mom and baby, but also because the mechanics of breastfeeding help your jaw, right?
Yes, and I love this topic, and whenever I talk about this aspect in particular, it's a sensitive topic in a lot of ways because it's a vulnerable time in life. And we live in a modern world. And so there's a lot that, of course, we wish for our children and we want to be able to do for the health of everybody that are not really practical in our modern life. So I like to at least acknowledge that everyone is doing the best they can for their children and their families. And it's not that anyone's doing anything wrong. And what's important to me is to just make sure I'm getting these messages out to as many families as possible so that they can make informed decisions and be empowered with this knowledge for their health as early as possible. So like you said, it starts with preconception, nutrition. It starts with being healthy before the pregnancy even starts. And then, of course, the health during the pregnancy. One of the things that I really focus on a lot, and I know that you have already interviewed Dr. Stasha Gomanak, but I'm trained with her and I study with her and follow her work as far as the importance of vitamin D, of course, during pregnancy and throughout development, so that we can really develop how we're supposed to and have the best health possible. So after that point, after we've gone through preconception and conception and then gestation, once we have an infant, it's so fascinating to me to see the anatomy. I'm so thankful to be able to work with breastfeeding families a lot in my work, helping them in conjunction with other providers be able to feed and achieve their feeding goals, whether it is breast or bottle feeding. Of course, we know one of my most important messages that I want to get out to the world is that the weight gain and nutrition are not the only goals of breastfeeding. And I think that's an important message that people understand. And of course, that is best, and we feed our babies as best possible. And it is a very sensitive topic, and there's a lot of factors that go into how we feed our babies. But to have the knowledge that it's not just about nutrition is important, because it does help begin to shape the jaws and the face and the airways from day one of life. Being able to encourage the forward growth of the face is breastfeeding, really. And then the way the tongue functions during extracting the milk from the breast, that shapes the jaws and it forms negative pressure and more obligate nasal breathers. So just the act of breastfeeding, it seals the oral cavity and it forces us to breathe through our nose. And that's the greatest start to life, because obviously nasal breathing is one of the most healthy things that we can learn to do and that we can do throughout our lives.
Mm-hmm. Yeah. I have a teacher that talks a lot about the design of humans. And so I like to think about it like, pretend you're reading about humans in a book, and they're like, oh, this species does this, and they breastfeed this long, and they eat these foods.
Right.
So it's kind of like, it's not about offending anybody, because certainly my views on nutrition, like I think that we should be eating organ meats and raw dairy and using lots of butter. Like, and a lot of people say like, no, that my mind has a different story about food. But I'm like, let's pretend that we had no stories about anything, and we're reading a book about humans, and we're saying, oh, humans do this and they do that so that they can do this. So like, I understand it's totally a sensitive topic. And I also think maybe if more people had knowledge that the mechanics of breastfeeding shape the airway and help the child become a nasal breather for life, that is just one more piece of information that can influence their decision as a family to what are we going to do?
I agree. And it's also important for providers to know that, because, a lot of these families get so much information from so many places. And at this time where you are exhausted, you are physically drained, you are not sleeping well, and it's really an overwhelming time. And so in order to, I think, make our best decisions, having this knowledge before we're ever at that vulnerable place is so key. And the providers also being aware. I know many families have this journey where if there is an issue with breastfeeding, we don't necessarily have the really trained support for how to accomplish our goals. And we don't always honor the mother's concerns if there is pain or if there is an issue with the breastfeeding journey, because we have so many options, we have so many alternatives that those end up being easy solutions in that moment. But if we are prepared and we establish goals and we understand the benefits, like you said, if we have that knowledge and support system really societally, then it makes that decision a little easier sometimes to be able to support a breastfeeding mother, because it takes a lot of support from a lot of places, whether that's our healthcare providers, our family structures, our community structures. All of those things really need to fall into place to enable this to happen. I understand, the complexity of this issue, but if we're looking objectively, like you said, as a human race, what is going to help us most with our development, it's extended breastfeeding followed by a hard, crunchy diet. So we know this from lots of scientific studies. So, the solutions to make that happen are complex for sure.
Right. Yeah, it's because the design is ancient and the world is modern. And so we understand it's not about being perfect. It's about understanding the design and how we can best fit it into this context in which we live.
For sure.
So you were saying, okay, so we want the jaw to move forward. So obviously I have, what's it called? What's it called? Like where you're
retrognathic.
Oh yeah.
That means set back.
Yeah. I mean, there's different degrees to it, but what we understand is that when it's back, the airway is constricted.
Correct.
And when it's forward, the airway is wider.
That's
So
it.
we want the airway to be wider. And we don't necessarily want the airway to be wider so we can get more oxygen, because one of the nice things about James Nestor's book is he gives carbon dioxide its role. Like, you know, because it's not just like, oh, we need more oxygen. We also need carbon dioxide.
We do. We do. It regulates a lot of our physiological processes, and we need, as a, humans need, if we're talking about objectively what humans need, we need a buildup of CO2 tolerance because it does regulate our physiological processes. So it's not that we necessarily need more oxygen, but we need a balance of the biochemistry. And as far as the airway goes, obviously I'm a structural provider, and I learn and in my work influence the kind of architecture of this space, but there's more to it than structure. There's, of course, the function, the biology, the biochemistry. And so that's what's so amazing about being able to collaborate with these providers, because the airway, which is how we take in air from the nose all the way down to the epiglottis, that area, there are many specialties along that line, along that track. And of course, our system is a bit more siloed, where we all have our own individual specialties. And that's where patients, I think, can get in this runaround where we're seeing a lot of people who know a lot about their area, but maybe are not as able to integrate these pieces. And that's where patients kind of are putting that together themselves. But we want to make sure that we can collaborate and understand also that the airway is a muscular tube. It is collapsible. And so that's not something that just because we give somebody a really giant airway, that even doesn't mean that we've helped their health, right? There's more to it than just giving a big airway. We want it to be toned. We want to be trained how to breathe properly, and we want it to not be collapsible.
Okay, so that makes sense. We want the structure and function to work in harmony, so that you're breathing not only more oxygen, but you've got also the right amount of CO2 and the right amount of oxygen as this breath happens. So you mentioned obligate nasal breathing or obligate nose breathing as breastfeeding as a way to train the baby to do that. But that means that we are almost always breathing through our nose, both in day and at night.
Right. And that means that goes back to your comment on design, right? So that's how we are designed to breathe, is through our noses. Mm-hmm. We do have our mouths as a backup mechanism, but that's not how we are designed to breathe. So unfortunately, in our modern world, that ends up happening more than we are designed for that to happen. And that has certain consequences for how we develop. And so by breathing through our mouths, we end up seeing a narrowing of the airway, of the arches. And then that means less room for teeth, which means less room for tongue, which means a more constricted airway behind those structures. And then it's a cycle where if you're trying to breathe in through your nose, but then everything behind it is constricted, then your body will do what it needs to survive. We need to eat, sleep, breathe, communicate. Your body's going to automatically know what to do. We're going to switch to breathing through the mouth, and then we're getting unfiltered air. So our nose is meant to slow, warm, and filter our air for us. There's a lot of systems for our nose to be able to do that by design. But if we bypass all of those functions, then something else has to do those jobs, right? So our tonsils and adenoids then need to filter the air, but that's the backup mechanism. So that has its own consequences that causes the inflammation, further constricting the airway. So it's all these cycles that are connected. And that's fascinating, but we want to make sure that we're trying to function how we're designed, and how do we enable those processes to happen.
So it's really common to see people like on buses or planes and they're like sleeping like this.
Yeah.
You know, like so many people just have their mouth wide open. They're breathing through their mouth when they sleep. And then it's also interesting to notice children, are their mouths closed when they're at rest, or when they're sleeping, are their mouths open? Because here's the issue. When we identify a breathing issue in children, so we notice that the child is breathing through their mouth and not through their nose, that's really the time to correct. Because
Absolutely.
One of the things that we'll talk about is it is possible to both work on structure and function, but it's much more ideal to fix issues with children because, right, their skulls are still, or everything's more pliable.
Yeah.
So at what age, because here's the issue too, so many children are so narrow. They already have crowded teeth. They, like you said, their structure is not permitting them to breathe through their nose. So you can't just tell them to close their mouth and whatever, because they can't. So I guess now maybe we should talk about that. Like, okay, so you have a child that's pretty young. You notice this child is breathing through their mouth at night, especially.
Mm-hmm.
What are you supposed to do?
This is the focus of my life's work, and I will be learning every day how to deal with this. But you're right. I mean, the time to act is when we identify the issue. And that issue, I mean, my youngest patient is 3 days old, right? Like, this issue is not, there's no one size fits all approach to it. There's no one thing that's going to help every patient. It's a complex topic that we need to do a lot of diagnostics to understand the why that's happening. And it's going to be multifactorial for everyone and involve many specialties. So my hope is that eventually this is more common knowledge. And once it becomes more common knowledge, more research is dedicated to this topic. Once more publications happen, about 10 years later, it makes it its way into the educational system. So we're a long way from this being standard of care, but what we're trying to do, the people now who are in practice, we can't wait for those changes. We're trying to implement these things now, patient by patient, day by day. So my role is to help either get families to where they need to go, or to help them myself if I can play a role. And those solutions look different for every age, but I do want to emphasize there are solutions for every age. And it's not that anybody is without hope. There are things that we can be working on all the time. So, I mean, we can kind of break it down by age, I guess. So by infants, we want to focus on encouraging the breastfeeding relationship, and identifying if there are any kind of concerns, whether that's pain from the mom, or sometimes it's weight gain from the baby, but sometimes it's gassiness or fussiness, or lots of other kind of, or snacking all the time and not having a long feeding, or falling asleep with the breast. There's lots of symptoms. And so My work with infants is if they've worked with a functional provider already, like a lactation consultant or a speech pathologist or an occupational therapist, and we've tried solutions as far as positioning and latch training and suck training and these kinds of things. If those are not making progress and we identify that there's an anatomical issue, then sometimes I release tongue ties. And we kind of, the umbrella term is tethered oral tissues. And that's something because it can be on the tongue, but it can also be the lips or the cheeks. And so
it's when you have like that
little, the frenum under the tongue.
But some people is like there.
Sometimes it's to the tip. Yeah. And so those are the really obvious ones. But there are some that are, I call them sneaky, right? It may not look restricted, but we know based on symptoms that there's something under the surface that's preventing the tongue to be able to lift. And so those kinds of support structures and interventions are how we would address an infant. Sometimes we need to involve an ear, nose, and throat provider. If there's another breathing issue, there can be a tonsil or adenoid issue, or issues around the larynx. Anywhere along this tube, right, can have some kind of malfunction or obstruction, even in the infant stage. I've had infants as young as 3 months already have sleep studies. So these are important things to look at the breathing patterns. Breathing shouldn't be noisy. It shouldn't be loud. And there shouldn't be snoring at any age, but especially in a child. So sometimes there are things an ear, nose, and throat doctor can do. Sometimes there are things a dentist can do. My team jokes that the babies don't have teeth. Why are they seeing a dentist? But yeah.
So the tongue tie, so basically cutting that tongue makes it so that the tongue is free to move in its proper place in the mouth. So I think this would be a good time to mention, where should the tongue be in the mouth? Does that change over the lifespan of a human, or no? The proper tongue position when we're just sitting down, like waiting for the bus, what is that tongue position?
All the time, the tongue should be fully resting in the roof of the mouth unless you're eating or speaking. So the resting posture, it should be, if this is the roof of your mouth and this is your tongue, they should be completely touching and flush. What's common, if there is some kind of tethered oral tissue or restriction, is that the tongue may not fully be engaged in the back part of the palate. And so we can lift the front part, but not the back part. And that's when we would identify some kind of restriction there. And there's lots of ways that we can train that musculature, and that's where function comes in. We don't want to overdiagnose. We don't want to, because everybody has a frenum. Everybody's tongue is connected to their body. So we want to make sure that we understand that's a normal structure and we should have it. Mm-hmm. But if we identify if there's an issue, if we're not able to achieve the functional goals of what the tongue should be able to do, we should be able to use the tongue in isolation in order to swallow and eat, as well as speak, without using other muscles around the mouth or the neck area, or using our posture to compensate. So compensations are a big thing that we talk about in this field, that yes, like we talked about, your body will figure out a way to eat, sleep, breathe, and communicate. But are we doing it the way we're designed to do it? So is the tongue able to swallow in isolation without recruiting lots of other muscles? And if not, why is that happening? Do we just need to strengthen? Do we just not know that we're supposed to be doing that? Or is there something in our way physically? And that's the work of diagnosing which route we go on. Are we going to be strengthening through things like myofunctional therapy? Or if we're hitting a wall with myofunctional therapy, where we've tried strengthening and toning and we're still not achieving our goals, that's when someone like me would come in to help with a restriction on the tongue to enable more movement and lift and range of motion. Regardless of age, a lot of people think of that as an infant issue, and it is, but that is a lifelong journey where we see adults as well.
Yeah, that's relatively new idea for me, that I could be aware of where my tongue is in my mouth. And now I'm super aware, like here's the top of my mouth and I make sure that my tongue is up there. But right, like having your tongue as a child pressing up against that upper palate means that the palate is all that helps to shape the palate and have it be wide enough, because you want your tongue to be able to fit inside of your teeth. My tongue does not, but also I'm very narrow, but you want, that's ideal, right? You've got your tongue is right up there, and your tongue is part of the reason why that happens, right? Because it's like pressing up against there.
Yes. Yeah. The tongue, I say, is like nature's orthodontics, right? And the position of the tongue dictates the shape that the arches will take. So we really want a high oral resting posture in order to shape the jaws to be basically an exact replica of the tongue. So we want it to look like a tongue imprint on the roof of the mouth. And then if the tongue is there all the time, the goal is that would shape the arches as they're supposed to be. And it forms that supported architecture. And if everything develops that way, then it stabilizes that way. And we don't see collapse, and we don't see changes as much if that's how we develop early on. But that's all determined on how we're breathing and how we're functioning. And that can change throughout life. There may be a season where there are lots of interesting studies. I mean, there was one about, a child who was developing normally with really even facial thirds, forward growth, everything we'd want to see. And then the family got a dog. And this dog caused a lot of allergies for the child. And the child was constantly stuffed up and had to switch to mouth breathing. And the article published shows severe stunting of the lower jaw growth based on the change in the breathing pattern. And so that just shows that maybe at one time point we were on track, but then something can happen to get us off track at any point. So it's important to be able to identify these things and understand the relationship, so that we can intervene and treat as it's needed throughout life. But like we said, even if you do every single thing right, where we're breastfeeding extendedly and we have a hard crunchy diet and we're breathing through our nose 100% of the time, we are still more narrow than we were many generations ago. So there's still the genetic component of our starting point. And so I think it's rare that we get to the point where we have all of our teeth and we have a wide open airway, space for our tongue, and no treatment is needed. It's just the nature of a modern skull now that we're just smaller.
Yeah. it's super wild, because imagine that boy never got the dog that he was allergic to.
Right.
He would look completely different.
Would look completely different.
And not only would he look different, his life would be different, because he would be breathing through his nose and not through his mouth. He would be more handsome. Like when you breathe, because the face, when we follow the design of humans, and we can see this in Dr. Price's book, because he has these beautiful pictures of these people, these wide dental arches and beautiful like energy. It's, when you breathe through your nose, because your structure supports that, you have energy. So you're beautiful, you radiate, like you can see the life force in this person. So, but isn't that incredible? It like goes back to what I said at the beginning. Like, it's not necessarily your genetic destiny, how you look when you look at yourself in the mirror. No. And that is like, if only people walk away with that is enough, because that is super wild to think that maybe this boy's literally the way he looks and the way he feels and the way he acts and the way his nervous system develops and his personality develops, it all was like because he got a dog that he was allergic to. That is a really wild thing to think about.
And isn't it interesting, with Dr. Price's work, we see the studying of the Aboriginal populations, and that's our control really in modern society, right? That there are populations who don't eat like modern Western people, right? And how did they develop versus how do we develop? And it is so fascinating to see that we have many examples of developing how we are intended and how we are designed. But it's crazy to see that, our modern lives just don't really support that. And then, it brings up all kinds of questions of, well, how do we deal with that then? We do live in a modern world, but we have a different potential. There's a different path that we can choose. And more people are understanding that and reading things like Breath to kind of at least ask the questions and find the providers that are going to be good to partner with and find solutions that are going to work, but complex for sure.
When I've traveled to other places now, like, unfortunately, there's Coca-Cola and there's fast foods. And so a lot of places that used to be more pristine and protected are no longer so. And it's also unfortunate because they don't necessarily have access to modern dentistry. Yeah. And so we can also see some of these issues in their most severe forms because there's no Band-Aids. So modern dentistry and orthodontics, okay, like someone like me, I was definitely a mouth breather when I was young. I had so many cavities, and now I know that has to do with the fact that I was breathing through my mouth at night, and it was drying my mouth out and changing my microbiome and making me susceptible to cavities. I also did not have a nutrient-dense diet. But, so then I go and I'm like this very typical kid. I've got cavities because I eat sugar.
Right.
And then, I'm in first grade and they're like, you know what, we're going to put braces on you. And then like a couple years later, they're like, we're going to do braces again. Like one of the things, and I can't find it right now, but in this book, in Breath, he says something that we're going to look back in 10 years and say that modern orthodontics was like the worst idea ever because that, okay, so maybe we should talk about this, is that like, this is the art of intervention. The art of life is the art of intelligent intervention, because it can be that braces maybe someone is putting braces on you to fix aesthetically that your teeth are crooked, but it could have an effect that's not good for your airway development.
Well, I want to start by saying that, of course, there's a lot of opinions on this topic and we're learning a lot.
Yes, I know.
That my orthodontic colleagues are doing a great job and following their training. But what we know is that we're seeing a paradigm shift, right? So we used to be really focused on, look, my training is teeth, and I'm going to make the teeth look beautiful and put them where they're supposed to be based on this educational paradigm, right? So we didn't have the information in the past about how that affects the airway and how that affects our breathing and our sleep. Now, more and more information is coming out, but again, it won't be standard of care until it's taught in schools. So there's a lot of uphill battle for anybody treating these conditions to know. But in general, we have seen a shift from retractive orthodontics to more functional based treatments. And so that's what we will start to see kind of more and more shifting from one to the other, because the mechanics that we use to grow jaws and position teeth can be airway positive, airway neutral, or airway negative, right? And I think more kind of in the 80s and the 90s, before we really knew much about this, there was a lot more of a general theory that if we retract everything, we can get everything lined up well. We can take out some teeth to make space for straight teeth. And then we've accomplished our job, and we did, right? That was the goal at the time. And so there's, like I said, a lot of controversy around this, but we are grateful to have the knowledge to be able to kind of shift how we're treating. So we want to make sure that now I am shifting from, do I have straight teeth, which is really no longer my concern, to, do I have room for my tongue inside my mouth? And that is going to look different for everybody, because everyone has a different size tongue. And everyone's posture is different. Everyone's facial structure is different. But that's really now the goal, is to have space for the tongue, so the tongue is not blocking the airway. And for children, that's a much easier fix than for adults, but there are solutions for all ages.
Okay, so one of the things that I mentioned is my tongue does not fit. My tongue does not fit inside.
It spills over your teeth when you lift it entirely.
Right, it spills over my teeth. So, but I'm an adult. So, and we know that you called it a suture before, because I talked to you, and it's like this part, maybe you can speak about it, like that fuses together at the roof of the mouth. But in a child, that's still movable. Yes. In an adult, not so much.
Again, a source of controversy. There are two bones that make up the upper jaw of the maxilla. And those, it's a suture, and it looks like a zigzag line is where those bones connect. We call it a suture. So that connection gets more and more integrated over time. It used to be thought that around puberty, around age 12, those bones fuse completely, and then that's it. Then it's sealed, set, done. We know now that's just not the case. That there are ways that we can now open that up in order to create more room in the roof of the mouth. So as a child, we can use lighter forces, or what we call tooth-borne expanders, where we're using the teeth as the anchors to widen the arches. But in an adult, if we do that, we would just be pushing teeth out of the bone rather than actually widening the palate. So we just need more forces and different forces to be able to remodel that area. So lots of different techniques and the source of lots of research and clinical application here now.
So children under 12 that still have that suture much more movable, they, and I've seen it on children, and we discussed it because it also is not, it's potentially an option for adults, but it's actually, it looks like a little box and you turn it and it literally separates that suture.
Yes.
New bone grows. Is that correct?
Yes. It's called a dental expander. It's a traditional orthodontic device, and there's many designs for those. But the traditional way is that you turn a key in a gear positioned in the center of the palate, and then that widens the arches.
Okay. And those are probably more effective for children because of this.
And what's important about my work is that we do want to make sure that we are considering both jaws. So there are some who are operating under the assumption that we should only be expanding the palate of a child if the upper jaw sits inside the lower jaw, meaning that the lower jaw is what sets our limit for how wide we can go. And it's true that there's no such suture in the lower jaw. So we can't just put an expander and then separate the middle area and new bone grows here. That's not what happens with the lower jaw. It's one single body here. But as far as our orthodontic norms, as far as what we want to see at each time point during development, I am operating under different goals as far as what I'm wanting to see in my patients. I prefer to take my benchmarks from the anthropology research. So we know that we want to hit certain widths by certain ages in order to be able to accommodate all the teeth. And so those are the norms that we are working off of, published in the 80s by Dr. Bogue. It's the Bogue Index, and that's what we are trying to achieve in our patients, which is sometimes a departure from other philosophies depending on where you're being seen. And so those are things that we want to make sure that we are acknowledging, that we want the upper jaw is what determines everything. It determines how far forward the lower jaw can go. It determines how wide the lower jaw can develop. So the earlier we can develop the upper jaw, the better, so that we can also allow the lower jaw to grow to that potential. And so it's important to me to make sure that I'm treatment planning both arches together, so that we can, whether it's even uprighting the teeth, where most patients have lower teeth that are leaning inward, and that takes up space that the tongue needs. So by the time we kind of straighten those lower teeth, it shows us how wide we can make the upper jaw. Because if everybody's teeth were like this, the upper jaws would look much smaller in comparison. But we're kind of looking at a false reading. when the teeth are leaned in and we're focused on the teeth. So that's why we want to focus more on the actual bony structures. How wide is the bone here? Where can I put the teeth to fully utilize all of the bone? We want the teeth centered in the bone. How early can I intervene to encourage that growth and go from there?
Okay, so that I understand. The suture's only at the top, and that's where we have
opportunity.
Right. That's where we have the opportunity. Of course, we can't, I get that. We can't expand the upper jaw so much so that it like doesn't fit with the lower jaw. So
right.
this is your like stationary constant.
Mm-hmm.
So in adults, one of the reasons why I had come to, well, the reason why I contacted Dr. Balfour and then contacted you is because in this book, they talk about something called a homeoblock, which I understand is something that's used in adults, not in children. And I think they call it a palate expander. I'm not sure. But then we get into that controversy of, can you really expand a palate of an adult? And you and I discussed, like, maybe it's actually doing something else. It's pushing the teeth out. So maybe we can talk about options for adults.
Yeah. So there are kind of two categories of interventions for adults if we want more jaw width to create more tongue space to improve breathing and sleeping. There are surgical and non-surgical solutions. What's a very hot topic right now is everyone really trying to find non-surgical solutions because it's a little bit easier to go through a treatment like that. No one wants to have surgery if they don't need it. And are there, simpler ways to improve our breathing and sleeping? So there's a lot of products out right now. I hesitate to speak about any of them specifically, but I do try to train on as many as possible because, of course, in your clinical experience, you're going to recommend what you know. And the more techniques in your toolbox that you know, the more you can understand when each one is appropriate in each situation. And I'm still on that learning curve, and I think really everybody is. And it's a long runway to even have the skill set to be able to implement any one of these. But there's probably 10 right now. The main non-surgical options, the question is, are we expanding the palate? Are we moving the teeth? Or some combination, right? Or are we doing some kind of orthopedic device? So some appliances claim that it's more about aligning the bones of the skull rather than the actual teeth. And that's an interesting concept to me because, like we talked about with the maxilla, there's two bones that are fused, connected on a suture for this bone. But not just that. Actually, I have my little visual aid right here.
That's good.
It's not just, here's my little skull. And I'm going to take off the mandible to show you. This is the maxilla. These two bones are connected. But you can see there's so many other connections, okay? There's the sphenoid bone here, the temporal bone, zygomatic bone. All of these sutures are an opportunity to realign things. And that's where, we get into other fields like craniosacral therapy. But, as you can see, that this is one solid bone structure. So there's no suture in the lower jaw, but every other area in the skull does have sutures. So the non-surgical techniques are claiming that we're kind of either realigning these sutures and kind of shifting these bony structures, because especially the sphenoid bone, that can kind of cause these torques and changes in the leveling of everything in the body. So that can cause, shoulders to be off and hips to be up or down and uneven, causing lots of changes throughout the body. So we do want to make sure that we're aligned. The other products, I think I'll just say that there's probably 3 brands of products that operate with that intention and philosophy. There's fewer actual published scientific literature about those concepts and those results long term, which leads to hesitancy of clinical providers from offering them. And we don't want to, of course, we want to operate under the do no harm philosophy as well. So in the effort to help patients, we don't want to do anything that would cause harm. And so we don't want to put forces on the teeth to push them out of the jaw. And that's the primary concern for the non-surgical solutions. There are some patients that are going to be good candidates for those kinds of interventions and some that are not. There are some patients that get amazing results from these kind of solutions and some that get no results. So it's important to go into all of this with humility and a sense of curiosity and reservation. The transitional technique that is considered non-surgical but does involve a little bit of surgery is maxillary skeletal expansion. I would say that as well as the surgical methods have the most published scientific literature. And so we do have more information on maxillary skeletal expansion is placing mini implants in the roof of the mouth along with a traditional dental expander in order to direct the forces along the roof of the mouth rather than the teeth to be able to separate the suture at the source. We are able to get pretty consistent results with that technique now. And lots of providers are publishing good success with pretty high predictability. It does involve minor surgery. There are small implants in the roof of the mouth, and sometimes there's also corticopunctures along the suture in order to help open that suture.
What kind of punctures?
They're called corticopunctures. It's where we would use various techniques to place indentations along this line. So we would kind of use various techniques to kind of drill into these bones along this suture and along this area here in order to help open that area. So the forces from the dental implants that are going to be along the roof of the mouth, that these these anchors would be more successful at opening if there's already like a beginning of an opening.
Or you can just have surgery and they literally just do, they just like do it manually.
So that's done in an outpatient setting where you come into a dental clinic and you're just numb and you're awake and you go home. So that's why we're considering it non-surgical, because it's along the lines of what happens with a dental implant, which we're routinely doing in a clinical setting. So then the next level is, like you said, actual jaw surgery. So the concern with doing maxillary skeletal expansion is the forces are only along this line. But there's a lot of other bones. The maxilla is still connected to this bone and this bone and this bone. So there's still other connections that may limit your ability to open this suture. So that's when we would start looking at, do we need to involve these other bony structures in order to separate the maxilla entirely and open it? Now, that also brings into question the 3 dimensions. There's the width, forward, and up and down. The only way to really get forward growth in an adult is surgically, where we're doing jaw surgery to move this jaw forward as well as the lower jaw.
Oh, yeah.
The only way to do that is surgically. So it depends on our goals and where we are with our current anatomy, our starting point, as to what is needed. I always try to gauge the severity of the symptoms as well as the severity of the craniofacial deficiency to offer patients solutions that are appropriate for them and their lifestyle and their goals.
So if you have surgery and you get wider, aren't you going to have a bunch of spaces in your teeth? Do they have to put fake teeth in there?
It's a great question. So it's done in conjunction with orthodontics. So there's the phase of surgery where we get the bones and the jaws where they should be, and then you close up the spaces and you align the teeth appropriately.
That just sounds just gnarly. I mean, that just sounds like really intense. But I guess some people have such severe airway breathing issues and sleep issues that they need like drastic measures are called for. Or maybe someone's also doing it for aesthetics because that's the thing. When we develop wider faces and chins that are forward, I mean, when we develop properly, we're more beautiful.
And that's what's so interesting is, of course, what's beautiful is healthy and what's healthy is beautiful.
Right, exactly.
And surgeries like that are life-changing. Those are amazing. We have amazing opportunities to be able to do those when it's appropriate. And I find that it's, the more I learn about it, the more I do think it is needed for a lot of patients. But then it goes back to my goal is to get them before that point. But there are solutions for all ages. Yeah.
Yes. I mean, it's like there are so many possibilities for intervention, starting all the way at the preconception diet in order to avoid having to do something that drastic as an adult, but it is there and available if needed. Okay, that's really fascinating. So what I can share about my own story is that I'm kind of considering getting a Cpap machine, which is, and I am taping my mouth at night, which we can also discuss briefly because I made up, even though people have seen my interview with Mark Burhenne and he talks about mouth taping, I made a post on Instagram and people are like, oh, that is horrible. And what if you are going to throw up? And what if you die? And but my body's so used to it now. It took me a long time to get used to it, but now my body's used to it and I have to do it. Otherwise, the next morning I feel if I don't mouth tape, I'm really tired. And if I do, I'm not tired. So, okay, that's a lot of things to talk about, but
let's touch on lip taping briefly. I do have a protocol for that. You're right. There are situations when it's appropriate and not appropriate. Of course, if we are taking sedative medications, if we are feeling unwell, if we have been drinking alcohol, these are not appropriate times to lip tape. However, and there are many different designs to lip tape. We can cover the mouth completely. We can cover the mouth partially. But lip taping is published and known to be beneficial for improving sleep. It is part of the Seattle protocol for the Spear Dental Solutions. It's a common dental continuing education group. There's a protocol that you go through to see which aspects of intervening in the airway are going to be appropriate for this person. It's a stepwise system that you go through, and that's the first step, because if all you need to do is lip tape, great. We're not going to do jaw surgery. So that, as well as, of course, researching the Buteyko method, and there's lots of it is becoming more and more commonplace, but we want to do it in an appropriate way. Children under age 3, of course, we would not be taping their lips. We want to start during the day to make sure we can tolerate it, that we can physically breathe through the nose. If there's an obstruction in the nose at all with the septum or turbinates or tonsils or adenoids, also not appropriate. So there's a lot to read about that and to know when it's good. And there are medical tapes that we recommend. 3M micropore tape is what I recommend to my patients. It's a breathable tape. There are other tapes. Somnifix is the really nice one that there is actually an opening inside of it for air if you need. There's Myotape for children that goes around the outside of the lips so that you could, again, still breathe if you needed to. If a child wanted to open their mouth, they could. The goal is to eventually not need the tape, right? That we are so strong myofunctionally and that all the structures are in balance to where that's not needed. But for a lot of us, that Band-Aid is the long-term solution. And that's okay.
Mm-hmm. Yeah. My experience is definitely that I can't just put one little piece of tape. I kind of need to be really shutting my mouth, but I'm also used to it. And I realized that at first it's just something that you almost can feel kind of panicked.
Yes.
Because because maybe you've been opening your mouth a lot and it's not even necessary. It's just a habit for your body. So when you change a habit, it can be frightening, but then it's totally okay.
Yeah. And then you touched on Cpap.
Mm-hmm.
That's a great solution for a lot of people. It's a non-surgical solution. It is an immediate fix to opening the airway and getting you breathing right now. And I think it's an important solution that obviously many people already seek, but even people in this field, sometimes shy away from things like that, but it's a very useful tool and should be used when appropriate. Where are you with it? Are you using one yet?
No, I need to call the sleep center. I haven't done it yet. I've just been mouth taping. I just feel so much better from mouth taping. But see, I know that I could feel even more better with the Cpap. But I kind of get in these things where it's like everybody, you get used to feeling a certain way and functioning in how you feel. But what I've realized is, now that I've started this whole journey with my sleep, I think for most of my life, I was completely exhausted. Like, I think for everything I've done pretty much up until now, I have birthed from a place of exhaustion, which means what could I do if I was birthing from a place of rest and not exhaustion?
It is amazing. We get these norms, right? Like we survive. And it is amazing that, patients can go through certain treatments and on the other side to say, gosh, I never knew how tired I really was until I was no longer tired. And so our baseline and our norm, it's great that we can function, but we're always questioning, so how can we be better and how can we feel our best? And that's what we want.
Right. I think that interviews like this are really important just because people can start to get an understanding. I mean, that's how I learned about all this stuff, is from YouTube. Like,
there's a lot online, a lot of resources.
Yeah, there's a lot online. The trickier part is finding a dentist or other health professional to work with, because so many dentists, I mean, that's what I think about. There were so many signs when I was not only young, but also an adult. And lots of dentists saw me. They never suggested that I might have a sleep problem. Also, I went to see functional medicine doctors, and functional medicine doctors would tell me, oh, you have adrenal fatigue. You need to take this herb, which is great, except that no herb can save you from lack of proper sleep, so it is a little bit, it can be daunting to navigate and find someone to support you on your journey, because there are great health professionals out there who don't know anything about this, which is a little mind-boggling to me, but
absolutely. Well, and we want to give ourselves grace, right? Especially the practitioners you saw growing up. This information was not available. And any person who's learning about this knows about it by seeking it out themselves. No one practicing now learned this in school. I want to be clear. And so we give ourselves grace, but it's important to understand who serves what role for our health.
Right.
We have great practitioners that we want to see for certain things. And what's difficult is that this is not really a specialty, right? This is not a recognized, official, board certified specialty. This is people running around like crazy, drinking from a fire hose all of the information they can from fields that are not their own. So as far as like finding a good team, it's difficult. But I also encourage patients to, like I said, utilize the strengths of your provider, right? It's not your pediatrician's job to be your lactation consultant.
Right.
So don't ask them to be. And so, as patients navigating that space can be difficult. I try to serve as a case manager role a lot of times, because it's not necessarily me that is the person that's needed in that case. It may be somebody else. But the more our specialties talk to each other, the better off patients are. So I love organizations like the AAPMD, which is marrying physicians and dentists in one organization, where we really have conferences dedicated to topics about the intersection of our fields. That's a great way to find providers who are involved in organizations like that.
What does that stand for? As you said, AAPMD?
Oh, goodness, I knew you'd ask that. American Association of Physicians
and Medical Doctors. It's okay. It doesn't matter. I don't
know what it stands for. I'll look it up.
I was just wondering because, well, also that's another thing, some of the people who are listening are going to be in other countries. So,
yeah,
I definitely recently somebody from Mark Berhenny's team reached out to me to see if I could connect them with dentists in other places because they are getting more inquiries. But I know there are dentists in other places doing these things. It's just a matter of,
So a lot of patients find me just from the various, like you said. So whether it's finding practitioners who you read about something and then you contact people specifically listed in those books, right? And I'm sure on your website, you probably have a list of books that are recommended. It's the American Academy of Physiological Medicine and Dentistry.
Oh, that's great.
And then there's lots of other organizations that I'm in that have lists of providers. Like the Breathe Institute is another one that is really great educational source. And they have a list of people who are trained in their methods. Airway Health Solutions has a directory for people involved in airway health. ICAP is like a tongue-tie organization. Orthotropics, Academy of Airway and Naphologic Orthopedics. There's lots of organizations that have lists of providers and the more you dig into it, the more you see, okay, I can go to this organization and I can look up providers there.
Okay. Yeah, I will definitely share in the video description. I will share information about, where people can go with some of these resources we've mentioned, just to look for.
And a lot of those I recognize are American.
But it's okay. It's also but that's the thing. You have to follow the thread. So maybe they have somebody in Miami who knows a dentist in Argentina.
Right.
So it's about, as many just resources that we can provide, then it's possible to follow threads and find people.
Yeah, I know Airway Health Solutions is international. I was in a course recently and I love online education now. We can really transcend boundaries and borders, because I was in a course just a couple weeks ago with someone from Mongolia. It's common for me to study with someone from Japan and Australia and Russia simultaneously. And somebody's up at 2 a.m, but somebody's it's 5 p.m. So it's amazing.
Yeah,
how we can connect.
Before we leave, I just wanted to mention, because we had talked several times about myofascial therapy, but we didn't talk too much about it. So can you explain exactly what that is? Because that might be another route, like maybe somebody before they even do another intervention would do myofascial therapy?
Yes. So I call it myofunctional therapy, and it is the common explanation I give is it's like Pilates for the tongue, but it's a lot more than that. So it's about how we can function with proper muscle balance in our face. So all muscles that touch the airway, just like we do physical therapy, or we might work out with a personal trainer at the gym, everything here is muscle structure. So we learn how to tone and isolate muscle groups in order to operate and function how we're designed. So that field is crucial to my work. We have to partner with our myofunctional therapists. That usually is either a speech language pathologist or dental hygienist or dentist or physical therapist who has gone for extra training beyond their licensed field originally. The two organizations that typically train are the IAOM and the AOMT. Please don't ask me what that stands for. Those organizations, you can look up providers through there. And that's another way, a great way to find providers. Really, it's the functional providers, whether it is speech pathology, occupational therapy, or myofunctional therapist, or lactation consultant. Those are the people who are going to know the structural providers like a dentist or an orthodontist who is doing this work. That is important because we want to think about how structure and function are functioning in harmony. Because it doesn't matter where I put the teeth, it doesn't matter how big the jaws are, if we do not have healthy breathing and sleeping habits and proper tone and muscle balance. And that's where the myofunctional therapy comes in. The general stage of how I approach patients is that we make sure that we have tongue tie, tongue tone, and tongue space. And that comes from the Breathe Institute, their teachings. But tongue space, meaning we have enough arch width, we have enough space up and down, side to side, and front to back. Mm-hmm. All three dimensions support the ability to have proper tongue resting posture. Then we have all of the tone and muscle strength that we need to use our muscle groups in isolation. And then if there's any issue anatomically restricting our oral tissues, that we address any ties that are there at the end of the treatment. So it's usually that kind of a sequence. We want to make sure we have the space, the tone, and then address if there's a tie. But those things in combination with healthy nutrition, healthy breathing habits, hard, crunchy diet, that's how we get to where we're supposed to be.
A hard country diet, you mean like eating beef jerky? Mm-hmm. I'm like 9.
It's more important for a growing child.
Right.
Because really bones form under stress, right? So we have the formation of bone as there's pressure. So eating should be a workout for growing children. If we eat softer foods, it's not going to develop the muscles in the jaws like we're supposed to. And so that's, we want to encourage appropriately eating hard, crunchy things, which is kind of a departure from the soft baby foods that we think of as feeding children.
Right, because now it's all these little puree things and like smoothies but I mean, maybe those are fine if there's also harder things present.
Right. It's not that we can't eat those things, right? We're in a modern world. We have things on the go, but as much as we can, we want to have those hard, crunchy foods and also devices, right? Like as a dentist, we help with certain oral appliances that serve as chew toys to help mimic that as well, to help mimic that diet.
Oh, cool.
So.
Hi, there's chew toys for dogs and chew toys for the kids.
Absolutely. Absolutely.
Okay, so we know that modern humans are narrow. We've got a lot of regeneration to be doing. And we've talked about so many different things. Maybe like to wrap this up, what can we leave people with? Like there is hope.
There is hope. There are providers out there who are actively learning and applying all of this. There are things that you can do, little things in your life to help improve breathing and sleeping, whether it's just lip taping, whether it's just being aware of where your tongue should be sitting in your mouth, encouraging breathing through your nose, lots of mindfulness, and there's lots of apps for all these things to help kind of learn about this and encourage these healthy habits. There are small things that we can do in our daily lives to help implement healthy habits. And seeking providers if you do want to look more into it. But I guess one thing you asked about that we didn't touch on yet is like why dentists are kind of at the center of this field.
Yeah.
Is that it's exciting that there are signs in the mouth of what's happening in the body. And we are the only ones trained to look in detail in the mouth. And so if we are looking carefully and we have the right training, there's so much that we can get from a simple exam. How much of the back of your throat can I see? What are the wear patterns on your teeth? Even just having wear on your front teeth, I know exactly what that means. I know that we need to look more at what's going on with your sleep. It doesn't mean automatically that there's a sleep issue, but there's enough clues for us to be asking more questions. And so there's a lot that we have opportunity, whether it's a narrow jaw or the tongue is laying low. All of these little signs tell us more about the system and the balance that's happening in that individual patient. So we want to make sure that it's exciting to be able to look at those signs and know who can we get this patient to, or what do we need to look at next. But it is specifically dentists who are able to look at this. And then we want to be able to have those medical colleagues to lean on and those functional colleagues to collaborate with so that we can get a patient a comprehensive and holistic approach.
Mm-hmm. Yeah, I think that's amazing. That step one is maybe just awareness. Is my mouth closed during the day? If I'm not talking, eating, where's my tongue?
Yes.
Let me look at the other people in my life and notice the way they're breathing. Like those are all really good first steps. Let me research more about mouth or lip taping. Let me talk to my dentist even about these things. Maybe my dentist knows about them and I didn't even know, or maybe so. It's totally, and I definitely honor that with myself and every other person and you as a dentist, because you're learning new things every day. It's just, we're all just learning every day. And maybe what we knew yesterday is something different than we know today. So, but awareness, and I think that's like the most practical, just walking away knowing that the tongue should be at the top. So the tip of the tongue is like kind of near the front teeth, but not pressing against, right?
Yeah, there's like, if you feel with your tongue, there's like some bumps behind your front teeth. Those are called the rugae. And so the tip of your tongue should be there. So whenever you say like the letter N, we call that the spot. So the tip of your tongue should be there. And then the rest of the body of the tongue should be flush against the roof of the mouth. And so sometimes that's harder than you think. Sometimes we have to really kind of like strain our neck to do that, or we have to kind of move our jaw forward to do that. We lift our eyebrows to do that. So there's a lot, those are all the compensations that may happen. And that's when you would get with a myofunctional therapist. And a lot of them, they do their work online. It's really amazing. So access to care through myofunctional therapy has become much more available. So we can seek a myofunctional therapist online to help us with that posture, and through them determine if any other steps are needed. So there may be very simple solutions for patients. Take comfort that if more interventions are needed, we do have the ability to do that now. And also, I would probably emphasize to look at the children in your life, and to see, are they breathing with their nose? And because we can all make a really big impact there.
Yeah, it's like really it's mostly for the children. It's so important because we really do have this potential to completely change the course of humanity, because we're changing the health of an entire generation when we work to make it so that their airways, both structurally and functionally, can breathe, can accommodate breath. I mean, breath is, it's life. Yeah, exactly. Breath is life. And so I'm so glad that practitioners like you exist, and thank you for your work in the world. And I will definitely put your information and about O'Shea Dentistry in the description of the video, so that people, some people that watch this are in the US, so you might get some people.
Thank you. Yeah, I have a center dedicated to the airway work that I do called the MyoGrow Center there at O'Shea Dentistry.
Oh, cool.
So passionate about that work and being able to collaborate with providers in my area, and see patients from all over. So really just, if we can help, let us know. And everyone's on a journey, and I like to meet patients where they are in that journey. And I'm always learning and growing too.
Totally. Well, thank you so much, Dr. Shannon. I hope that you have a great day. And
thank you for having me, Katie. I really appreciate the opportunity.
Yeah, I'm so grateful to get this out to the world.
All right. Thanks so much.
Okay, thanks. Bye.
Bye.